Well, it looks like it's right at the top of the hour, so we're going to be getting started. Good evening, and thank you so much for joining us for our latest clinical education webinar, Skin Cancer 101, The Cancer You See. My name is Kim Montanarello from VisualDx. Before we get started, I do have a few housekeeping notes. This webinar is being recorded and will be shared with all registrants. We encourage questions from the audience, so please submit your questions in the Q&A box and we'll get to as many as we can once the live lecture is complete. Following the clinical presentation, we're going to test your skills with the Kahoot quiz, awarding a prize to the winner. It'll be a $100 Amazon gift card, so you'll want to have that app downloaded. I'll write it in the chat once I get done with the introductions to let you know if you haven't downloaded the app already. Also, we ask that you take a survey that we have at the end because your feedback is so critically important. Now I'd like to welcome back our presenter, Dr. Azeen Sadeghian. Dr. Sadeghian is a board-certified dermatologist from Baton Rouge, Louisiana, currently seeing patients at Baton Rouge General Physicians. Dr. Sadeghian's expertise is in diagnosing and treating a wide range of conditions affecting the skin, hair, and nails. She is passionate about patient care and education. Professionally, she's active in the Louisiana State Medical Society, sits on the advisory board for the American Academy of Dermatology, and serves as the editorial committee chair for the Women's Dermatologic Society. She's also currently a voluntary adjunct assistant professor at Tulane Health Sciences Center. We're so happy to have her here today because it is Skin Cancer Awareness Month, and she hopefully has wonderful nuggets and information to share with you today. Without further ado, Dr. Sadeghian.
Thank you, Kim, for that introduction. Welcome, everybody. Thank you for coming out to listen to this webinar. I hope you guys are able to glean a lot of information from it. Please feel free to ask questions, and we will definitely get to as many as we can. Skin cancer is something that I'm very passionate about. Obviously all of dermatology, I truly do love all of dermatology, but skin cancer is something where you have the potential to make a very huge impact based off of a physical exam finding, and it can be life-saving. So I know everybody kind of remembers the Seinfeld episode where Dr. Pimple Popper, but I do want to emphasize dermatology is not pimple popping. I think right now it's really popular on cable TV. You have Dr. Pimple Popper, but actually anybody who spots a skin cancer is really truly a lifesaver. So that could be a hairdresser, that could be a nurse, that could be a medical assistant, that could be a spouse. And there's even stories of dogs who are, have sniffed out skin cancer on their owners before. So you guys are here today, so we are going to try to equip you to be lifesavers, and that is our goal today. So why does skin cancer matter? More people are diagnosed with skin cancer than all other forms of cancer combined. And that makes sense because you think about the skin being the largest organ and it's on the outside of you. It is exposed to all forms of radiation. And you just have a lot more skin. So a lot of that is capable of turning into a cancer. So 1 in 5 people will develop skin cancer by the age of 70. And having 5 or more sunburns doubles your risk of melanoma. And I'm here in Baton Rouge, Louisiana, and I will say we have a lot of people who their skin was probably not designed for southern latitudes, and they live in a state where we are outside all the time. And so sunburns are so common in the South. And so that is something to ask your patients. What are the objectives of our presentation today? I really want to adjust your threshold to consider skin cancer, especially because all of us see skin. We see our own skin and we see other people's skin. And so I really want to adjust that threshold, and it should always be in your differential. I want you to have more confidence in identifying skin cancer. A lot of spots look the same, and so it can be really tricky, even for a dermatologist. There are times where, it's really hard to diagnose a skin cancer. Also, to help triage patients appropriately, you might not be the one who's performing the biopsy, but perhaps you're the one who says, hey, I really think you need to see your dermatologist about it. And then ultimately to save lives. And patients' medical care does include skin, okay? It is an organ of the body, and so it is appropriate to appropriately treat and manage the skin. So let's talk about our skin cancers. There are multiple forms of skin cancer, but I really want to focus on the big three. These are the ones that you are most likely to cross paths with at some point in your career, and if you haven't already. So that's your basal cell carcinoma, okay? You also have your squamous cell carcinoma, and you also have melanoma, okay? Melanoma is kind of the scary one. There are some less commonly known ones, and these are the tricky ones. They're even difficult for dermatologists to diagnose, and that's your Merkel cell carcinoma and your skin lymphomas. And there are various other skin cancer or cancers that occur within the skin, because you have to think about the skin. And I'm going to show you a diagram on the next slide, but you have, vasculature in the skin that can become cancer. You have, fibroblast and all sorts of different cells within the skin. Any of those can become cancer. And so we're not going to talk about these, the ones that are grade, but I do recommend try to look these up to become familiar with them. These are not ones that you're guaranteed to come across, but it is something that's worth learning about. And these aren't necessarily technically what we consider like keratinocyte-derived skin cancers, but they can occur within the skin. Okay, so let's talk about the skin model, okay? And I'm gonna see if I can kind of show you with a little laser pointer. The top layer of the skin is made out of keratinocytes, and the keratinocytes are kind of what you think about skin cells, and they produce the keratin and the outer layer of the skin that kind of makes our skin nice and water resistant to some extent. These can become cancer. So you also have at the bottom of the epidermis basal cells. These can become cancer. And then you also have melanocytes, or your pigment cells, at the bottom of the epidermis, and these can also become cancer. So when you think about your keratinocytes, your squamous keratinocytes, if those become cancer, that's a squamous cell carcinoma. Your basal cells are a type of keratinocyte as well, and if those become cancer, that becomes a basal cell carcinoma. And then melanocytes are pigment cells. If those become cancer, that becomes melanoma. And so you definitely have other skin appendages. You have all sorts of skin structures. Like I said, anything can go rogue, but the ones we're going to really focus on are the big three. And we'll talk about the derivation of other skin cancers as we move forward. So I do want to dispel some myths, because there are a lot of myths about skin cancer. I think the number one myth is that skin cancer doesn't kill you. And so fortunately, there are some forms of skin cancer that don't kill you. And I'm going to show you kind of the contrast, the truths from the myths in a little bit. Another myth is that skin cancer only needs to be cut out and you're done with it. And I actually have a lot of patients who will see me. They maybe got diagnosed with a skin cancer 20 years ago, and they're like, oh, I got it cut out, and so I never came back for a skin check. That's definitely not what we should be doing. Another myth is once you're cured, you're fine. And I'll kind of tell you why that's not true. This is the biggest one, and I'm very grateful for VisualDx for having a project impact that they're doing, which is trying to dispel healthcare disparities due to race. But this is a big myth that only white people get skin cancer. This is not true. All races, all ethnicities can get skin cancer. If you have skin, you can get skin cancer. And then another myth is you only get skin cancer in sun-exposed sites. So these myths are based on partial truths. And so let's kind of dispel them with some truths. Okay, many skin cancers are not fatal, but there are life-threatening types. Many skin cancers can spread if left untreated, and some can spread even despite treatment if they're locally aggressive, or if maybe they were diagnosed later. Also, if somebody's ever been diagnosed with a skin cancer, there are many situations where we need to continue examinations and skin checks to monitor for spread. So we will check lymph nodes during our skin checks if somebody's had a higher risk skin cancer. They're also at higher risk of developing other cancerous lesions because of something called field damage. This is more the case for, our UV-induced skin cancers. And so anyone who's ever had a diagnosis of skin cancer should always have a routine skin check. And then we already talked about how all races get skin cancer. African Americans, Asians, Hispanics, everybody can get skin cancer. And then lastly, skin cancer can occur on any site of the skin, even the genitals, the nails. The nails are a part of the skin structure, or even the bottoms of the feet. So Bob Marley is a prime example. He was African American, and he got melanoma to the bottom of his foot, and it was fatal. So okay. Oh, Kim, I see that somebody is raising their hand. If you can, let me know if you need me to pause. I have a hard time kind of navigating that while I'm.
No, we just have those that are raising their hand to put questions in the Q&A box, and we'll get it to at the end. So I don't want to interrupt. You can continue your presentation.
Okay, thank you. And thank you guys for asking questions too. That's great. Okay, so what are some of our at-risk populations? Well, if you're at risk for UV damage, so who is at risk for UV damage? Think about your fair skin patients, your patients who don't really have a lot of melanin. Your melanin does help you, your pigment does kind of help you against the sun. And it's actually kind of cool because the pigment is dispersed in a way in the cells to try to protect the skin cells, DNA. So the less pigment you have in your skin, you are technically at more risk. And we know that people who have like blonde hair, blue eyes, or very fair skin, or red hair, their pigment is made a little bit differently than people who have darker pigment, especially brown pigment. If a patient burns easily, that is also a sign that they are at risk for UV damage. Other at-risk populations include people who have a family history of melanoma. So I do recommend anybody who has a first-degree relative with melanoma get a routine skin check. If somebody has multiple moles, like more than 50 moles, or they have dysplastic nevi or atypical nevi, they should be monitored. And then having a personal history of skin cancer. We already talked about that was a risk factor. Chronic UV exposure is another one. So people, blistering sunburns, that's not good, right? Or multiple sunburns. There are occupations that predispose you to UV exposure. And I primarily think of our welders. Welding puts out UVC radiation, which is more carcinogenic to the skin than sun. And then pilots, they are exposed to a lot of radiation, especially while flying. Tanning bed use. Tanning beds used to be marketed as safe tanning. It is not. It is carcinogenic to the skin. So if they have a remote history or current history, I recommend routine skin checks. And when I mean remote history, they might say, oh, I used to use tanning beds when I was in high school, but I stopped. That is a history, that damage has been done, and they need to be monitored. Now, there are some medical conditions that should definitely prompt additional consideration prior to you thinking of your differential or diagnosis. And the one I really want to focus on is, immunosuppression. And that could be for medication. So think of even like your organ transplant patients who they're immunosuppressed because we have to dampen their immune system so they don't reject their organs. We know these patients have a higher risk of skin cancer. Immunocompromised patients should be monitored. Some patients are born with either genetic disorders that predispose them to skin cancer or cancer disorders. And then scarring skin conditions can also increase the risk of skin cancer, especially within the scar site. And then if you have a history of radiation treatment to an affected site. So I do want to talk about some warning signs of skin cancer. And these are things that you can kind of pick up on if the patient is talking to you. Or maybe you can pick up on this when you're asking your questions. So I really want to know is this spot growing? Is it changing? Does it bleed? Is it symptomatic? If they're mentioning it to you, that means we should probably be following it up with some more questions. Is it not healing? For example, sometimes you'll have a patient who says, every time I wash my face, I have this like one little spot on my nose, and it won't ever heal. Sometimes it bleeds, and Sometimes it acts like it's healing and then it just kind of comes back in the same spot, but it never completely heals. That is a red flag. Another thing is a lot of people, they'll end up with a bobo, or as I say to my patients, they'll end up with like a scab or something, and they're like, you know what, I must have bumped myself there, but they don't recall the trauma and the skin doesn't heal. That's kind of a sign. So maybe we should follow up on this. Is it not responding to appropriate treatment? I had a patient one time who had a spot that we thought was nummular eczema, and it was just a single spot. After she'd been treated appropriately to clear it up, and it didn't clear up, we biopsied it. It was actually squamous cell in situ. Another warning sign is the spot friable on exam. Is it easily denuded? And what I mean by that is, like, if the skin's not as structurally together as we would expect. And so if I take like a piece of gauze, and I rub on it, is it going to start bleeding? Is it going to kind of crumble apart? Does the top layer of the skin easily come off with just minimal friction with gauze? Another warning sign, is it arising within a chronic scar or wound? Okay. For example, like for a discoid lupus patient, do they have a spot that is eroded? The skin is partially missing there within a chronic discoid lupus scar, or is it within a wound? Did they have a burn and there's a part where the skin all of a sudden, after 20 years after the scar happened, after the burn happened, they have an area that all of a sudden is starting to ulcerate. That's arising within a chronic wound or scar. Also, like, let's say if somebody has a long-standing ulcer of some sort and things are changing, you do want to consider skin cancer. Another thing is actinic damage or radiation. So you can easily spot actinic damage. It's literally it's such a stark contrast between, especially in the South, we have, our patients, their arms might be heavily damaged, and then their stomachs, if they wore a t-shirt their whole lives, their stomachs look fabulous, or like their bottoms, the skin is just no damage whatsoever. And that kind of shows you that difference between chronic sun exposure and then protecting your skin. Radiation sites. And so we do have a lot of patients who are surviving cancers. And so we see radiation sites, people who've had breast cancer or lung cancer or even thyroid cancer. And you see if you have a spot arising in one of their former radiation sites, that's important. So getting an appropriate medical history will really help you kind of think, is this something I need to be concerned about skin cancer? So let's start with the meat of our presentation. Let's talk about basal cells. Basal cells are the most common form of skin cancer. And fortunately, the most common form of skin cancer is not the most aggressive. And so I think this is where we get some of our myths from, that, all forms of skin cancer, are just, you don't have to worry about them and things. Basal cell rarely spreads, but it is locally destructive. And I actually recall somebody, my intern year, who had a basal cell that hadn't been treated for decades. And when I tell you it locally, I shouldn't even say locally, it continues to destroy. It just keeps eating at structures, and it just kind of, so you definitely want to treat it. There are definitely various subtypes of basal cell carcinoma, and I do think that's beyond the scope of what we are trying to get to in this lecture, because my goal is just to get you comfortable recognizing and spotting these and identifying these, especially in different subtypes of skin and different Fitzpatrick types of skin. So there are various subtypes of basal cell carcinoma. We have infiltrative, sclerosing, nodular, there's, superficial basal cells, all these different types, but that's not as important as it's a skin cancer and it's a basal cell carcinoma for our intents and purposes here right now. What are some risk factors for developing basal cell? We do know that this one is one where UV radiation is a risk factor. So chronic sun exposure particularly is a risk factor. And then patients who have fair skin types are more at risk. The most common presentation of this is what we call a pink pearly papule with telangiectasia, What does that kind of mean in non-dermatology language? Is a pink bump with broken blood vessels within it. There are other presentations though. They can be pigmented, they can be ulcerated, but I think the clue is you oftentimes see a very like prominent kind of blood vessel. And you can see here, this one has an arborizing kind of vessel, and this one you can kind of spot the blood vessel. Now here, this patient has a pigmented variant, okay? A lot of times you see kind of this pearly border. You see how it kind of reflects the light differently than the rest of the skin? And so that kind of textural change is a clue that this is not healthy skin compared to the patient's other skin. Now, this one can be tricky because when it first forms, patients might think it is a pimple. And in fact, that is something I commonly hear. I have this spot, I thought it was a pimple. I kept trying to pop it. Nothing ever came out of it. And it's starting to get bigger. Well, definitely not a pimple, but you can see how maybe when it starts, it looks like something like that. It's starting out as a pink bump. So I tell my patients, anytime you get a pimple, scab, or bobo, if it pops up and it's not gone in 3 to 4 weeks, we really need to know about it. So here are some other images, and I just want to emphasize that although fairer skin patients are more at risk for developing basal cell carcinoma, all skin types can develop it. I've seen basal cell carcinomas in African American women, even in Hispanics and Asians. So any race can get it. But let's kind of look at these pictures because I think a picture is worth 1,000 words. Now, this picture in the top left, you see this very pearly papule, and you see these large telangiectasias in here. And then this has a little bit of a superficial eschar scab that shows you, anytime you see kind of crusted blood or scab, that shows you that the skin is not healing as it should if it's long standing. Now, the only times it's really appropriate to have a healthy scab, I would consider, is if you had trauma to the skin, you scraped yourself, or you got a cut or an abrasion or something like that, and your skin's trying to heal in, then yeah, you're going to have a healing process that involves, maybe some heme crust and possibly a scab. But you shouldn't just have it happen on the skin for no reason. Now let's go to the top right. Now this is a darker skin type. I would say this is probably a Fitzpatrick 4 to 5, most likely 5. And you see this is a pigmented lesion, right? This patient's capable of making pigment. And so I wouldn't be shocked to see a darker skin lesion. And so, but you see here, this one's pearly too. And you see how it has that kind of rolled border. And this one kind of looks similar. You see how that little central dell right here? It kind of looks like that. Now, let's look at the bottom right. This one's a little bit harder. It almost looks like an indentation of the skin, but you can kind of tell right here. You see how it reflects the light differently? This is also irregularly shaped, and I can faintly make out that little broken blood vessel in there. That's a clue. This is not good. In some forms of basal cells, instead of puffing up, they kind of depress down, okay? So it doesn't have to be raised to be a skin cancer. It can be sunken in. Now this is a prime example of if something is not caught early, it can continue to grow and be locally destructive. This is a large basal cell carcinoma and a darker skin type. Once again, likely a Fitzpatrick type 4 to 5. And you can see here the borders of it, the texture looks different. Now this one might not look as obviously pearly. Sometimes it kind of helps to look at all of the borders. And you see here, this area does look a little bit more shiny, but this area is ulcerated. I mean, the skin is missing. It's not able to heal in. Cancerous skin cells, they don't like to be team players, okay? They don't connect to each other like healthy skin cells do. And so that's why you can kind of see this friable nature or erosions or ulcerations in cancer. Okay, that was a lot of ground for basal cell, but we covered the most common form of skin cancer. So kudos to you guys for hanging in there. Let's talk about the second most common form, and that's squamous cell carcinoma. Now, Squamous cell carcinoma can occur anywhere. And I think a lot of different specialties have encountered squamous cell carcinoma because we do have squamous cells other outside of the skin. So you can develop squamous cell carcinoma inside of the mouth or mucosal surfaces. And so even rectal cancer. And so, but we're going to talk about squamous cell carcinoma of the skin. Risk factors, again, UV radiation. And I would say this one's more of a broad spectrum, meaning, if you think about somebody who's had radiation exposure as cancer treatment, I think of squamous cell carcinoma being at risk for squamous cell down the line. Photo exposure as well. So if somebody's had a lot of sun damage. Now, immunosuppression is another risk factor for squamous cell carcinoma. HPV, we know HPV is associated with squamous elsewhere as well. Chemical exposures, fair skin, chronic wound scars, and this one's a little bit of a longer list. You do have potential for invasion and metastases with squamous cell carcinoma, and the risk varies based off of the subtype. And a lot of times your biopsy will tell you how aggressive a squamous cell carcinoma is. The location also can dictate your risk of spread. So high risk areas are mucosal surfaces. So like the lips, head and neck, ears, those are areas where if left untreated, you're more worried about spread than, let's say, like the forearm. You do want to monitor your patients who have squamous cell carcinoma, especially if they're large or extensive skin cancers or with aggressive subtypes. And monitoring patients will entail checking their lymph nodes. Now, like I said, anybody who's ever been diagnosed with skin cancer needs routine skin checks. But palpating for lymph nodes is going to be important for our squamous cell carcinoma patients. Now, what is a classic finding? It is an erythematous scaling plaque. And in English, in our non-derm language, what that means is kind of a pink to red scaling spot on the skin. It tends to be raised. Now, there are other presentations. You can get a nodule, which is kind of like a big bump, an ulcer where the skin's missing. There are various other findings, and sometimes it can look like a wart. And then a very unique presentation is something called a cutaneous horn. Now, these can also erode where that top layer of skin kind of goes, doesn't stick on, and they can ulcerate. And that means that your epidermis, that whole portion of the epidermis is gone and you're exposing dermis. Bleeding, these can be symptomatic, like itching, tingling, painful, tender. This is another spot where it keeps recurring, right? So if the patient's like, I have this spot on the tip of my nose, it's not healing whenever I wash my face, that could be another clue of skin cancer. And then duration, if the spot has been there for like 2 days, I'm a little less worried. But if it's been there for over 4 weeks, many months, years, the longer it's been there, the more worried I am. And your best test is always to biopsy, and your treatment of choice is surgical. Now, there are some other treatment options, but I do not think that they should be decided upon without a dermatologist really being involved, because those treatment options are not the gold standard. So, yeah. Okay, well, let's talk about the pictures here. Now, this is a darker Fitzpatrick type again, probably a Fitzpatrick 5 skin type. And this patient is capable of making pigment, but we see here that this is not the darkest skin cancer, although the border is hyperpigmented. This might be mistaken for being a large wart by somebody, but it is not. And then here, this is a completely different presentation. You have an erythematous scaling flat papule with some heme crust on it. And so you can tell that this is a spot that's not healing well. Let's look at some other pictures. Now, squamous cell carcinomas can occur from the nail bed as well. So, a skin check should always include the nails. And you can see here, this patient has definitely a friable plaque at the nail bed. And you can see the skin is just, this would probably, if you rubbed it with gauze, would probably end up with some blood on it. Now, this is a patient who has, I could picture this in two different situations. This might be a patient who presented with this as a primary lesion, but what if you had a patient who had discoid lupus? In this spot, all of a sudden, she had a non-healing spot within her discoid lupus scar. So, all races can be affected by squamous cell carcinoma. Here we see a lighter skin type, likely a Fitzpatrick 2. And you see here it's an erythematous scaling papule. Like I said, mucosal skin can be affected, genital skin can be affected. Here's an example of a genital ulceration that turned out to be squamous cell carcinoma. Okay, and we know HPV is a risk factor. So you do want to consider a non-healing lesion on the genital area. You do want to consider skin cancer along with your other differential items, which may include venereal disease, but you want to keep your differential broad. Here you have a large non-healing, you have a plaque, part of it is raised and scaly, the other part half looks like it is ulcerated. Here we go. Next, we're going to talk about melanoma. Now, this is a cancer that nobody likes any cancer, but this is one that really makes patients nervous and it makes physicians nervous. Melanoma is an aggressive tumor of melanocytes, and it can metastasize, and it can occur anywhere in any race. There's multiple subtypes. Risk factors include family or personal history of melanoma, history of severe or blistering sunburns, having a changing mole, like changing in size, shape, color, texture, having a giant congenital nevus. These aren't like little birthmarks that you're born with, but these are giant. They're usually greater than 20 centimeters. Being older, having a lighter skin type, and then or having multiple atypical nevi, or having a history of tanning bed use. The ABCDEs are kind of our little mnemonic for melanoma, and we're going to review that. Some other clues is if you have a patient who has multiple moles, they have a mole, it doesn't look like melanoma, but it doesn't match any of their other moles. That's still a clue to me that you need to evaluate that mole. We call it the ugly duckling sign. If you have a new symptomatic or changing mole, not all melanomas come from moles, so you have to really be vigilant about this. If you're going to biopsy it, it has to be an excisional biopsy, okay? And then when we treat it, we cut it out with wide margins. We do lymph node exams and skin checks frequently on these patients. Whether or not we have lymph node dissection is going to be based off of, or imaging studies is going to be based off of the Breslow depth, which is the depth from the granular layer of the skin to the deepest portion of the melanoma. Now let's look at some pictures. Now melanomas can be very obvious, like these I think are more obvious ones. You can tell these are not normal spots. They have multiple colors. They're not symmetrical. They have, they're larger than 6 millimeters, or the size of a pencil eraser for here and here, and likely this one as well. But you see areas like here, this has regression, like the body's trying to attack it and it's kind of taking the pigment with it. And so this looks like the body is losing against attacking this. Now, melanoma can even occur in the nail unit as well. And so we do need to be conscientious of that. So we can see here all the different various presentations of melanoma. Melanoma, hopefully it will have pigment. And most of the time it does. But there are times there is an amelanotic melanoma, which is really hard. And it's that's a little bit more complicated in the scope of this practice. And I'll say that's even challenging for me as a dermatologist. I fear amelanotic, like missing an amelanotic melanoma. But for the most part, you will see irregular pigment throughout the lesions. And you see here on the foot of an African-American patient, you see a very irregular, almost black patch. And that's an area that we do need to start checking for more frequently. I feel like a lot of times we screen lighter skin types for skin cancer, and sometimes we forget to ask our darker skin types, hey, do you have any spots that we need to look at, or why don't we encourage you to kind of get a skin check and let's look at all of your spots, including the bottom of your feet and your nails. So the ABCDEs of melanoma, I kind of touched on them briefly, but A is for asymmetry, B is for irregular border, C is for color. If you have non-uniform pigment or multiple colors, 2 or more colors, varying shades or hues of color, that's a concern, or if the color is variegated. D is diameter. smaller than a pencil eraser is considered okay, and then larger than a pencil eraser is a little bit more concerning. But melanomas can be smaller. I mean, they have to start somewhere, right? So, you know, you want to add all these clues together. And I think E is very important. E is evolving. Is the spot changing over time? Is it growing? Ulceration and bleeding are red flags. And like we talked about the ugly duckling rule, a spot that either just looks ugly or doesn't match their other spots. Okay, now we're getting to kind of the one cancers you might not ever come across clinically, unless you're a dermatologist, or you know, you have a patient who's kind of getting one of the more uncommon skin cancers. Merkel cell carcinoma is a rare, fortunately rare skin cancer. It's also known as cutaneous neuroendocrine carcinoma, which kind of shows you where we think the derivation is the Merkel cell. And it's neuroendocrine and epithelial at the same time. It's more common in the head and neck in Northern European older gentlemen. Immunocompromised, UV exposure, increase your risk, and there is a Merkel cell polyoma virus, but there's polyoma virus negative Merkel cells, and those can be more aggressive. It's usually an asymptomatic solitary nodule, so kind of a nondescript, maybe pink or red bump that's asymptomatic. A lot of times it can be smooth looking, sometimes it can be friable and bleeding. This requires aggressive treatment, and recurrence rates are high and metastases are common, and the 5-year relative survival rate is pretty low. Now you can see here, this might be mistaken for a basal cell, but either way, when you look at this, you're like, this spot needs to go, you know, but I don't think anybody would look at these spots and say this is a healthy skin spot, and so you would want to sample those. Next is skin lymphoma. There are multiple types of skin lymphomas, but the most common is something called cutaneous T-cell lymphoma. And skin lymphomas encompass a very broad range of lymphocyte neoplasm in the skin, because any immune cell in the skin can become neoplastic, but cutaneous T-cell lymphoma references the T cells in the skin that have become neoplastic. And within CTCL, the most common form is called mitosis fungoides. And this consists of erythematous patches or erythematous eczematous plaques with fine scale. Sometimes you can get tumors, and this one's a little different than other skin cancers because it likes sun-protected areas. So it really likes what we call the double covered area. So underneath the bra, underneath the underwear. It's often misdiagnosed as eczema. So if you have a patient who develops eczema in adulthood, especially later in adulthood, you really need to consider, like, is this the correct diagnosis or could this be something else? Now, patients can also present with plaques, nodules, and tumors. The best test is biopsy, and you really do need a pathologist who knows how to diagnose CTCL, because it's even challenging to diagnose under a microscope. And you can see here, this patient has eczematous-like plaques, and they are in double covered areas. You know, it's under, this is not an area that he gets sun in. So mitosis fungoides is twice as more common in males than females. In the US, African Americans do have twice the incidence over Northern European descent, but differences will decrease with age. So the median age is in the 50s, but any age group can be affected. African American, especially females with early onset, have a worse prognosis. So here are some other images that you can see. And you can see here at the top lesion, it almost looks like a fungal infection. And that's, you know, the mycosis fungoides kind of gives you that hint that, like, this is kind of what it looks like. But, you know, the thing is, these are not fungal. And oftentimes patients don't just have one spot, they tend to have multiple. So one of the variants, which is a notable variant, is hypopigmented MF. And this is a variant that you see in African descent. It can also be reported in those who just have, you know, maybe some pigment in their skin, Fitzpatrick 3 or darker. And it's also the most common variant in children. And you see you have these light little hypopigmented macules, patches, or xerotic-like plaques on the body. Okay. So how do you know when to refer, how to biopsy? I would say you really want to refer to dermatology to diagnose skin cancer of the skin, nails, and even external genitalia. And if you are the person who's doing biopsies, you want to make sure that you're sending to somebody who's a dermatopathologist who's trained to look at skin under the microscope, because skin is a very kind of tricky organ to look at under the microscope. You also want to consider a dermatology referral if you're not really sure if it's benign or if there's warning signs, or if you just think a patient's high risk. In those situations, a lot of times we do something called a total body skin exam, where we check patients head to toe. And we do those for our cancer patients who are getting routine skin cancer screenings. So let's say if you did a biopsy or your dermatologist did a biopsy, the top line is going to be the diagnosis, but it's important not to just read that top line, but the microscopic, because the subtype is just as important as the type of cancer. But on top of that, there's sometimes very important clues in there. For example, a biopsy might have only gotten the top layer of skin, and the paragraph underneath it might say, hey, although this looks like a superficial cancer, we can't tell if it's deeper or not. And so they kind of leave it open-ended. And so, that it's important. A lot of times your paragraph beneath the headline will give you really important clues. And so sometimes you do need to rebiopsy due to biopsy limitations. For example, this has happened to me before. You take a biopsy and you didn't go deep enough. It might be a cosmetically sensitive area like the nose. So if you're uncertain, you might not take a huge biopsy, because otherwise a patient would have a big scar on their nose. So you take a small biopsy and the pathologist says, hey, I need more skin. And so, okay, let's talk about treatments of skin cancer so you can kind of be familiar with it. Skin cancer is most commonly treated outpatient by dermatology. And we usually use localized numbing like lidocaine to numb the skin. And then we kind of cut it out, sew it back together. But there are other forms of destruction that are used if appropriate. For example, under certain circumstances, chemotherapy creams or electrodesiccation and curettage can be used, where we kind of scrape and burn the skin. There is something called Mohs surgery. Mohs surgery is a unique form of surgery where a surgeon kind of, instead of taking margins, cuts closely around the cancer, and they map it out to see where do they need to cut out more. This is important for high risk skin cancers, or larger skin cancers where you don't have a lot of skin to cut out, tight locations or sensitive locations, or the need for tissue sparing. This is also outpatient. Excuse me, I do need to take a sip of water. So there are Mohs criteria that you can find online to help you kind of triage, does this need to go to Mohs or not. Imaging is not often empirically done except for aggressive tumors. So for example, like melanomas at a certain depth, or I'm so sorry, guys. Oh, hope y'all have like a little soda or sparkling water nearby, so you guys can stay hydrated too during this talk. So yeah, melanomas with a certain depth or staging might need imaging, merkel cell, and some squamous cell situations if you palpate lymph nodes. Inpatient surgery is usually not needed, but exceptions do exist. So you want to talk to your derm or Mohs surgeon first if needed. And in certain instances, we do need to coordinate with surgical oncology or oncology. For example, large tumors that involve gross disfigurement or extension of deep tissues or other organ structures, or need large reconstruction, or you're concerned about metastatic nodes. Plastics are rarely needed unless if you don't have a Mohs surgeon, or if you have something that's going to cause gross disfigurement. And but talk to your team. People will point you in the right direction. And then sometimes ENT is needed if you need extensive head and neck reconstruction as well, or you're concerned about invasion of deeper structures. So what are some great resources? The American Academy of Dermatology has the Mohs appropriate use criteria, and it's free for everybody to access to view that article. American Cancer Society, cancer.org, they have some information about skin cancer. The Skin Cancer Foundation at skincancer.org has some great information too. You can point patients to that website as well. VisualDx, and I'm not saying this because I'm a VisualDx groupie. I do love VisualDx, but in terms of their images, it is, I mean, compared to none, because this is one of the few databases where you can compare skin cancers in different Fitzpatrick's types. So meaning I can look at skin cancers of all races and skin colors and really get familiar with it, because a lot of times we get familiar with learning, I can only spot skin cancer maybe in one skin type, but not another. And so we don't want to miss anything. They also have a cool module called Learn Derm, and they can, the module also has a portion where you can learn how to perform a skin exam. So, okay, with benign lesions, let's say a patient comes in, you're like, you know what, that looks like a benign spot, a seborrheic keratoses, which is a throwback to our diagnosing on the spot lecture. So if you're reassuring a patient, always let them know to contact you if their lesion changes at all, changes in size, shape, color, texture, anything. Or if it becomes symptomatic, like is it starting to itch, burn, bleed, anything. If it gets a tingle, I want them to call the office because it needs to be reevaluated. Perfect example, I had a patient I diagnosed with a sebaceous gland hyperplasia. It was tiny, it was here. You know what, 2 months later, she's like, it's gotten bigger. We biopsied it, it was basal cell. So, you know, we are human and we're limited by what we see in that one time frame. And so you always want to caution your patients for this. So that's the end of the lecture. Thank you guys for hanging in there, and especially while I had my little cough spasm. I know we have a great Kahoot quiz for you guys. It's tough this time. Last time I was a little too easy on y'all, so be prepared.
Well, thank you so much, Dr. Sadeghian. And I just put in the chat, we did do a great webinar on solitary lesions because we did have some questions about the differential diagnosis of some of these skin cancers.
Yeah.
And I would welcome everyone to check out that webinar. And I put the link where you could find that webinar. But let's go through a couple of Q&A if at all possible before we get to the Kahoot. So someone had a question about if any radiation treatment not related to the skin can be one of the risk factors of skin cancer.
So for example, when patients with breast cancer get radiation, that radiation has to penetrate through the skin to get to the breast tissue. Also head and neck tumors, that radiation has to penetrate through the skin. And so you can even ask your patients like, hey, did you get a burn from your radiation treatment, or did you get any kind of darkening of your skin or any kind of like changes in your skin? A lot of times they will tell you, yeah, I got darker there or got drier there. And a lot of times, you know, they'll get gritted out. And so, yeah, oftentimes the skin is affected even if it's targeting another organ. Now there is skin radiation for CTCL, and that's different. If you're doing skin radiation, it's usually for something that you're concerned about being skin lymphoma. And so we don't really do that for other treatments. Now that's different from phototherapy. Phototherapy is not skin radiation. That's a completely different category than skin radiation. That when we talk about like what a radiology oncologist would be doing.
And then another question, is there any noticeable difference in length of development time-wise between the skin cancers?
No, because skin cancers do not read textbooks. And so I tell my patients that you can have very slow growing basal cells and squamous cells, and you have some that a patient will literally be like, this popped up within a month and it's like a big nodule. So I would like to say that the time frame would help you, but in most cases, it doesn't tell you this is one skin cancer over another. But I will say anything that's rapidly growing, you need to be concerned it's some form of skin cancer and make sure it gets taken care of immediately. That was a good question.
That's a great question. I think on that point, I'm gonna ask you to stop sharing your screen so that I can share my screen getting into the Kahoot. Some more Q&As might be coming in, Dr. Sadeghian, so if you wouldn't mind maybe just reviewing them while we do the Kahoot, and maybe you can answer them while I get the Kahoot going.
Sounds good.
1 second, let me share my screen. Okay, so you should be seeing the Kahoot and the pin. So as I always like to tell people, it's always best, if at all possible, to have this on 2 different devices. So, answer the questions on your phone, but maybe on a desktop, actually see the questions. Again, we're going to give away a $100 Amazon gift card to the winner. So we hope you all do well. And Dr. Sadeghian was the one that actually put together the Kahoot, and she says it is a little difficult. So, but I say, if we're going to give out a prize, we should try to test your knowledge if at all possible. While we're waiting just for people to log on, I just want to make mention of that we are constantly having events and webinars throughout the year. VisualDx.com/events is where you can find upcoming webinars. And we have some great ones coming up this summer that will be announced soon. So we appreciate you all taking time out of this Tuesday evening to learn with us. And one more thing I want to mention is, and one thing that Azeen did also talk about, is Project Impact. ProjectImpact.org is a global effort that VisualDx is working with collaborators to bring awareness about bias and racism in medicine when it comes to skin of color, and providing a resources hub for those that might want to learn more, whether it's textbooks or digital tools or patient-facing tools, things that can help provide better care to our patients of color. So it's a free resource. Again, we're part of it, but other collaborators include NEJM Group, the Skin of Color Society, AAD. So we're really excited to be really spearheading this effort this year, both in 2021 and beyond. And on that note, I think we'll be ready to go. So at this point, I'm going to go on mute. And I hope everyone does well, and we'll see you on the flip side of the quiz. Good luck. Okay, well, everyone did a really wonderful job. Congratulations to AD, who came in third. Second place, and our winner for this evening is ATG. So I will be in touch with you. And again, thanks everyone for participating. And again, I want to thank one more time to our esteemed presenter, Dr. Azeen Sadeghian. Great educational program this evening. And again, thank you to all of you for spending your Tuesday with us. With that said, thank you so much. Again, this is being recorded and we'll be sharing this with all attendees, and hope you have a wonderful evening. Thank you so much. Bye.